Good afternoon. Welcome to Penn LDI's fourth virtual seminar. My name is David Grandy. I am Penn LDI's Director of Policy. Through these seminars, we're addressing a range of important issues related to the COVID-19 pandemic. And frankly, there's not been a lot of good news related to the COVID pandemic, but one glimmer of hope has been how we can use these virtual platforms to connect across our campus, across our city, region, and even nationally. For what are very important discussions during this time. I do want to mention, again, this is the fourth event. We do have another event coming up on May 8th, where we'll focus on how the COVID pandemic is impacting the opioid epidemic. But today, we're focused on the crisis in post-acute care. And when we decided to host this event, we were a bit hesitant to use the word crisis, but I do think that is where we are today. The World Health Organization announced yesterday that up to half of those who have died from COVID-19 in Europe were residents in long-term care facilities. And we've heard similar numbers even from one of our nearby counties here in the Philadelphia region. We've also heard reporting out of New York that estimates that more than 2% of residents of nursing facilities have died from COVID-19. And in New Jersey, more than 95% of facilities now have positive cases. This is despite the fact that residents of nursing facilities are isolated in their rooms, that visitation has generally been cut off, and some facilities are even restricting COVID admissions altogether. At the same time, there are concerns about inadequate testing in nursing facilities, our workforce in nursing facilities being stretched too thin, and PPE being in short supply. So the big question we plan to tackle today is what needs to be done to make post-acute care safe and effective. And some of this care needs to happen in skilled nursing facilities, but much of it can also happen at home. And so we're looking at all dimensions of post-acute care today. And it's an important question, not just for patients with COVID, but of course for many patients with other health conditions that happen to be relevant right now during this pandemic. So we have an outstanding panel today. I'm going to introduce our four panelists to get us started. First is Rachel Warner, who's a physician, health economist, and executive director of Penn's Leonard Davis Institute of Health Economics, and one of the nation's leading experts on post-acute care system in America. Next is Josh Wee, a geriatrician at Penn and the medical director of a skilled nursing facility in Philadelphia. He's been part of national discussions with nursing homes around the country to try to meet the challenge of COVID-19. Next up, we have Ashley Ritter, a geriatric nurse practitioner and a PhD-trained researcher. She has both clinical and research expertise on post-acute care and has recently written on the fragile financial status of nursing homes and how the COVID pandemic creates an enormous stress on this system. And then lastly, we have Nina O'Connor, a palliative care physician, and she is Chief of Palliative Care for Penn Medicine and Chief Medical Officer of Penn Medicine at Home. In that role, she's pioneering ways for home care programs to respond to the COVID-19 pandemic to safely care for people in their homes. And so thank you to all four of our panelists for joining this discussion today. And I do want to start with a question for Josh. So Josh, the prevalence, as I've just mentioned, of COVID and mortality in nursing homes has been extremely high. It's becoming a bigger problem, not a smaller problem, it seems, in many communities around the country. And I'm interested in hearing your perspective on what you see as some of the challenges in managing this epidemic in nursing homes.
This infection has been like no other infection we've ever managed in a nursing home setting. And I would say the key feature of this infection is asymptomatic spread. And it's the idea that the infection is still really contagious in both staff and patients who have no symptoms. So most nursing homes that I know that have their first identified case, once they swab their nursing home or they swab a wing, they go from 1 case to 10 to 20 in about a week. Because the infection was already quite present. So the asymptomatic spread is a tough one. Social distancing isn't possible in a nursing home. The patients require hours of daily care in very close quarters. And then both from a staffing capability and then PPE and testing capability. No nursing home has enough testing, PPE, or staffing to deal with this infection that actually takes out a lot of our staff just as we're trying to increase our capabilities.
Ashley, I know you recently wrote about some of the financial situations facing nursing homes and some of the stresses that the pandemic may be placing on facilities. Could you talk more about what some of those issues are?
Nursing homes are primarily reimbursed by state and federal government. Payment for long-term care residents, the individuals who live in nursing homes, most often come from Medicaid. Medicaid pays not just for younger individuals who require nursing home care, but also low-income older adults. And Medicaid typically pays at a rate lower than Medicare. After a hospitalization, Medicare provides skilled nursing benefits for individuals with a skilled need. So think of physical therapy, skilled nursing care such as wound care, and this care is reimbursed at a higher rate than Medicaid. So both the long-term care and post-acute care in nursing homes is expensive. And there's been efforts to move some of that care into community settings through Medicaid waiver programs and bundled payments for things like joint replacement. And as a result, nursing home occupancy has declined over time. And when there's empty beds, there's lost revenue. With many facilities during the current pandemic currently closed to admissions, Medicare revenue is declining significantly. In addition, our long-term care residents are dying in many of these facilities, and these beds are unlikely to be filled in the near future, with expectations that this pandemic will continue for the next 18 to 24 months. The fixed costs of rent and personnel and the additional costs of PPE threaten to bankrupt our long-term care facilities. And that's the case for both individually owned, but also our chains. Without these nursing homes, community organizations and families will be required to provide care and housing for a population that has some pretty significant needs.
For a lot of nursing homes, before the pandemic, they were already facing declining occupancy rates. And then at the same time, the revenues they get from Medicare, which is largely focused on patients being discharged from the hospital, has higher margins than what they see with more long-term residents. Is that correct?
That's correct.
Okay.
So as we lose our post-acute care patients, that was really the moneymaker for nursing homes, and we're unable to bring safely individuals from hospitals into nursing homes at this current time. In many places, there are things you can do, but it's a huge challenge to facilities at this time.
And do we have any sense yet of how much the spigot that you're talking about of patients coming into nursing facilities covered by Medicare, do we have data yet on how much that's declined during the pandemic, or too early to say?
I have not seen data, but if you think about like a flu outbreak, when you have a few cases of flu, you're unable to admit patients to facilities during that time. So what I'm seeing is facilities closed to admissions because they have active infections, or feeling that they're unprepared to take residents from hospitals and therefore closing off admissions for that reason.
Both Josh and Ashley talked about some of the challenges within facilities themselves, but as we think about post-acute care, obviously we zoom out to a much broader set of places where people can be getting care, including the home. And so, Rachel, I want to turn to you because you've looked at this question on the costs and outcomes of sending patients to skilled nursing facilities versus sending patients home and what some of those trade-offs may be. Can you shed some light on what we know from the literature on this question?
Sure. So just to take a step back and provide some context, post-acute care we typically think of as the care that patients get after they're discharged from the hospital when they're not quite ready to go home and live independently, but they have specific skilled needs that they need help with, either help with their activities of daily living or IV antibiotics or some other continued care that they need that doesn't require continued hospitalization, but they're not ready to be at home on their own anymore. The vast majority of post-acute care occurs in one of two settings. One is what Ashley and Josh have been talking about, which is in nursing homes. We usually refer to that as skilled nursing facilities in this case. It's a segment of the nursing homes where this Medicare reimbursed rehabilitation for patients occurs over approximately 20 days on average. The other large portion of patients go home and get visits from a home health agency. As you can imagine, the care that happens at a skilled nursing facility is much more intensive than the care that happens at home. In a skilled nursing facility, people typically have monitoring or they have staff in-house 24 hours a day, 7 days a week, and can take care of a higher acuity level of patients. Whereas at home, the way the Medicare benefit is currently set up, which a lot of insurers follow, patients can get at most one visit a day, and so it's a much more limited set of needs that can be cared for through the home health agency. Despite that, there's some patients in the middle that could go either home or to skilled nursing facilities. And we've done some research in the past looking at which setting is better for patients. And so this was in the pre-COVID era, looking at patients who could have gone either home or to a home with home health or to a skilled nursing facility. And we found that, not surprisingly, patients that go home with home health are more likely to be readmitted to the hospital within 30 days of hospital discharge than patients who go to a skilled nursing facility. And I say not surprisingly because, as I said, patients in skilled nursing facilities get much more routine monitoring, have much more access to staff, and the skilled nursing facility can often treat conditions in the facility that we couldn't normally treat at home. And so there appears to be a trade-off in terms of patient outcomes. Not surprisingly, there's also a trade-off in terms of costs. Patients who go home are much less expensive to the insurer than patients who go to a skilled nursing facility because it's a non-institutional setting. And as a result, there's been a big push to get people home instead of to skilled nursing facilities. As we try and constrain healthcare spending and reduce healthcare costs, more and more patients are being sent straight home with a home health visit rather than to a skilled nursing facility, but potentially with the trade-off being higher readmission rates from that setting.
Nina, I want to turn to you. So obviously you're in a leadership role in home healthcare. And I'm interested in how COVID and the current environment that we're in is stressing that home care model. I know Rachel, just described, some of the limitations on payment and what can be reimbursed in home care systems. And so what were the stresses on that system before? What's changing during the COVID pandemic in terms of creating opportunities to unleash this system in a more robust way?
In many ways, the coronavirus pandemic is revealing the strengths and the importance of home care, because we now have a situation in which, for many public health reasons, figuring out ways to care for sick patients at home is actually better than sending patients to facilities in terms of reduced exposures and reduced transmissions, especially as our nursing facilities are stressed. So we actually have found that home care has been a really effective model for coronavirus. I'm part of a consortium of home health agencies in southeastern Pennsylvania, and the number of patients they're caring for and the ways they've innovated to be able to deliver this care is really inspiring. To give you a little bit of context as well, so Penn Medicine Home Health has 180 COVID positive patients at home that they're caring for that are actually fairly sick with high acuity. And then the hospitals have 355 patients today total. So about a good proportion of the COVID positive patients in Penn Medicine at the moment are receiving care at home, which I think is a testament to the fact that this really can work. There are certainly some challenges that the home health model faces with coronavirus. One of them is, Rachel, what you mentioned, that home care doesn't provide 24-hour care. And in a normal setting, we rely a lot on private duty or on family caregivers to supplement what home health does. Typically, this works very well for many patients, but there's reduced availability of private duty at the moment, especially for patients who are COVID positive, and then family members at the moment might be sick or might be reluctant to go into the home to take care of somebody. So that's certainly one issue. I think the other trend we've seen is that some patients are afraid to have home care come into their home during the pandemic. Everybody's focused on social distancing, staying apart. And so we've really been able to develop a lot of technology to deliver home care in new ways. And for each patient, we determine the right mix of virtual visits and in-person visits according to their preferences and according to their clinical needs. This is something we've always done. We've always provided some remote monitoring, some virtual visits, especially nursing, but we're doing more of that, and we've extended that in creative ways to other disciplines like physical therapy, giving people protocols for therapy exercises, supervising them through video visits, occupational therapy, and even some counseling and mental health services we're doing virtually.
At this point, have things changed in terms of policies coming down from, Medicare or insurers in terms of, what they're willing to pay for, what level of services can be reimbursed in the home? Is that something that we have answers to yet, or are we all just hoping at this point that some things that we're doing now that we'll find a way to finance them later?
We're getting some relief. We got relief on the homebound criteria, so anybody who has coronavirus, that counts, which is really good. Some of the payers are paying for telehealth visits instead of in-person visits for home health, which is wonderful. Hospice, we've gotten a lot of flexibility to do virtual visits and coordination instead of in-person care from CMS. So I think as time is going on, we're getting some relief in all of those, and then obviously we'll continue to work on that. It's a little bit payer specific.
I want to dig into this home care issue a bit more, and then we'll turn back to some of the stresses within skilled nursing facilities and get Josh and Ashley back into the conversation. But Rachel, you've written about some ideas in the Health Affairs blog this week about some policy changes that could really help in terms of supporting the home care model during the pandemic, and perhaps things that might even endure after the pandemic. Could you talk a little bit more about some of the ways you think policy could be more responsive to the situation we face today?
As Nina described, I think there has been some great examples of how to use home health care or home care to successfully care for patients during the COVID epidemic at home. And Medicare has loosened a lot of restrictions during the past 6 weeks to try and accommodate the pandemic. And one of the ones that they have really changed is their reimbursement for telehealth. So telehealth is now available for many conditions, whereas it used to be only available in limited circumstances. And as Nina said, it can successfully be used to extend the care that we give to people at home after hospital discharge. So you can imagine people are getting rehab consultations by telehealth at home. People can get telehealth from physicians, from mental health providers, from all sorts of providers to help supplement the care that they get at home. Telehealth is also probably very useful to address one of the concerns that people have, which Nina mentioned, related to allowing people into their home during the COVID epidemic and being concerned about the spread of the disease. With telehealth, the number of people who have to come into your home is obviously limited. But you do need to have somebody at home to help care for patients when they come home from the hospital with COVID-19. Typically, this has fallen on the backs of caregivers, so family or friends who are able to provide care to somebody who is at home. I think for this model to be successful, to really care for people at home after the COVID epidemic, we should fully incorporate caregivers into the care team and pay them for their time to do this. Caregivers typically are not paid for the care that they give, except under some circumstances unrelated to post-acute care. And by paying caregivers, we accomplish a few things. One is we really make care available for patients when they come home from the hospital. We relieve those caregivers of other duties that they may have to attend to during that post-acute care period, so they can both help their loved one recover from the acute illness and also limit their interactions with the outside world, so they wouldn't have to go to work other places and risk exposure to infection. And then we also can give people much more support at home than we would be able to without them. If they truly become integrated into the care team, and we pay physicians to work with caregivers to support the rehabilitation of patients at home, it can be a much more successful model to helping people rehabilitate at home. So I think the combination of paying caregivers and telehealth can go a long way in providing care at home in the post-acute period. And I think to supplement that, we probably need more monitoring at home, a lot of which is being done in isolated cases, but is not uniformly paid for. So we could imagine a scenario where you can have 24-hour a day, 7-day a week monitoring remotely that's feeds into a remote team that can provide impact. And then we could also have increase the number of visits that people can get a day. And so if they need to have someone come in more than once a day, insurers could pay for that, and that could help assist people to get really much more intensive care at home than they've been able to before. And so this is really a model that I think of as being more like having a SNF at home. It's really moving the type of post-acute care that people need out of institutional settings and into a home-based setting. And I think it's feasible with the proper supports to be able to do that.
The idea of paying caregivers, what has been the resistance to that idea in the past? I think a lot of people are looking at the pandemic as maybe unsticking a lot of past debates where we've been stuck. And what's been the major source of resistance to doing that in the past? Is it just money, or is it something else?
Part of it, I think, is that we have a very medicalized model of care in this country and what we pay for. So ever since the beginning of Medicare and Medicaid in the 1960s, they only paid for care that was delivered by licensed providers or institutes. And so I think that's part of where the resistance to paying caregivers come from. It's just not part of our healthcare model, but it also costs money. I will say on the flip side, in a long-term care setting, there are a number of states that have who have tried to, so Medicaid pays for long-term care in healthcare, in nursing homes in this country for certain people. In order to try and reduce the amount of money that Medicaid is spending on long-term care, they have, in some states, actively tried to get people out of nursing homes by paying caregivers to keep people at home through something called Medicaid waivers. And these have been met with some success. And so there are examples where we do pay caregivers to provide long-term care and supports for people at home. Generally, we don't pay them enough, though. And so people who are caregivers face huge losses, both in terms of their lost wages, but also mental health and other health consequences of being a long-term caregiver. And so we could do a lot more in supporting caregivers.
So I want to turn back to some facility level issues and get Ashley and Josh back into the conversation here. There's been a huge amount of attention to how we think about protecting the workforce and protecting patients in hospitalized settings. And it's not clear that there's been as much attention to how to think about these issues and how to properly resource skilled nursing facilities in the same way the conversation is happening around hospitals. Josh, let me start with you. What's your observations, not just here in Philadelphia, but in your conversations with other nursing home leaders around the country around the struggles that facilities are facing in terms of getting adequate PPE and even having adequate workforce to really care for patients in a time where the system is being highly stressed?
The challenge with PPE is universal. Certainly we don't have enough of it. Nursing homes don't stock enough PPE for a pandemic, and all the supplies have gone really to hospital settings. So here in West Philly, I know a nursing home that ran out of gloves. I know another nursing home that has no eye shields. I don't think any nursing home has enough gowns, including mine. And certainly nobody has enough N95s. So for example, one Friday I was doing CPR on a patient by myself because nobody else had an N95 mask or a PAPR. And I had to wait until EMS came doing chest compressions and bagging. And we've had problems with PPE where we've had 4 nursing home nurses die from coronavirus in West Philly. None of that made the news. None of that gets recognized. And so the PPE shortage, where the hospitals are getting the bulk of the supplies and the nursing homes are short, actually just exacerbates the problem. And so either the PPE will be used in a hospital setting to treat patients, or they can be used in a nursing home patient population to prevent them. But that is definitely a challenge. The staffing shortages, most nursing homes don't run with a staff that they can surge to the nursing home, like a health system can surge their outpatient docs to inpatient service. Most nursing homes use agency nurses on occasion. So when you have 20 to 30% of your staff get infected or told that they can't work between two different buildings, just as you're trying to increase your level of care, suddenly you're really, really short. And there isn't a pool of staff to pull from like an agency. They can't supply that much staff. And so staffing shortages have been really brutal. And then the other thing in terms of allocation that has been really tough is testing. So right now in Philadelphia, we do tons of drive-through testing, but we would love to have 7,500 tests to just swab all the nursing homes once. But the testing is allocated to outpatient settings. And so the nursing home is left with very, very few tools in this pandemic.
It strikes me that at least in the past couple of weeks, people's eyes are being opened to this idea that we have a major problem in skilled nursing facilities. And up until now, have you seen any sort of response coming from state or federal government to try to address those concerns that you just described?
I think we're sort of in bystander outrage mode, and we're slowly activating to useful interventions. So there's a lot of interventions that are happening on paper and look good in terms of the actual help that's getting to nursing homes. It's not quite there in terms of the will of the government to actually shift resources, to shift supplies. I'm hopeful that it'll get there. But yeah, it's still not fully activated yet.
So Ashley, I know you have focused some of your work on workforce issues and thinking again about some of the comments that I think Josh was just alluding to about the kind of leanness of the workforce in a lot of facilities. How do you see the need and demand changing for nurses and nursing assistants, and what can we do about it to try to? Are there ways to kind of flex up and respond to a surge in need in the way that hospitals have had a little more flexibility to do?
I want to echo what Josh is saying, that there's no backup care team for nursing homes right now. There's no substitutes for the direct care workforce, and we really need to protect them and plan to scale them moving forward. And it's just so horrible that as we have increasing care needs, our workforce is actually shrinking. So some things about the nursing home workforce is that they're predominantly female. They often identify as a racial or ethnic minority, and they're paid minimum wage or at least less than their hospital counterparts to take care of individuals in nursing homes. And they've been treated as an expendable resource in many places with extremely high rates of turnover and burnout. And the common practice of using staffing agencies to, fill the gaps in your workforce, falls short in some very significant ways when you're facing a pandemic, in that they can't go back and forth to other facilities. That actually increases the risk of transmission, and the pool is not such that you can surge it. So everything that we do needs to really recruit, protect, train, and retain our nursing workforce. I think one of the biggest things we could do is we could stop calling nursing home death pits. Behind every sobering story are 5 stories of a frontline worker that's treating a very vulnerable and dying individual with dignity and skill, and we must tell these stories. I also think that, without protection with PPE, we're going to continue to lose lives. And so we need to create systems that can distribute PPE in an equitable fashion. And much of that needs to be done at the state and local Department of Health level. The other is that we need to build and retain teams to work within facilities. Nursing home care is a team sport. You need all individuals in place to be able to work on that team and feel that they are trusted, that they're protected, and that they can deliver better outcomes. Some options to do that would be to, protect and pay them, but also to recruit from new graduates and community settings, as typically nursing home staff comes from the area that's local to them. So I think that we need to think about doing some work locally to recruit and retain, providing some federal funding to support this workforce, and ensuring that we're protecting these individuals.
I know that there's certainly been a lot written about graduating medical students, being graduated early, putting into the physician workforce, but perhaps not as much attention to some of the issues you're talking about, which is, are there ways to surge the workforce in some fashion through our training programs? Or is that conversation happening in nursing? Is it being held up in certain ways?
Many states are licensing, they're continuing their licensing capacity, but there are hang-ups right now with nurses and nurse practitioners completing their clinical training. With many sites being closed to clinical training, the same things that have happened with graduate medical education have not happened at such a broad scale with nurses, where they're able to attain their hours to reach graduation, or contingency models have been made to enable nurses to practice with either an early graduate license, similar to some of the things that have happened with physicians. There are nursing students at all levels, associate programs, bachelor's programs, graduate DNP programs, and we need to activate that workforce that has incredible skill and move them into the places that they're needed, but we need to protect them as well as we move them into these settings.
I want to turn to some questions that have been submitted, and I would encourage people to continue to submit them. We'll see how many we can get to. But we have a question here. Since nursing homes are understaffed and many are overwhelmed with their own COVID cases, should government and public health officials use or create other locations for discharged hospital patients? So the idea being separate skilled nursing facilities or even temporary facilities being stood up in some fashion that is specific to patients being discharged today.
So the idea of a COVID SNF that actually has adequate staffing, PPE, infection control policies to protect non-COVID patients means that you need everything from completely cohorted staff and supplies down to housekeeping and food management, and some medical directors even believe separate HVAC units, separate entrances, and most nursing homes don't have this physical type of plant to have a true COVID wing or a true COVID SNF. Because if you have staff going back and forth between your COVID wing and your non-COVID wing, then it's not really a COVID wing. You've just introduced infection to the rest of the building. And so since most nursing homes can't physically do this, and they don't have the resources to build a new hospital or a new wing, then there's going to have to be some support from the government. Otherwise, we're just going to continuously introduce infections into COVID naive buildings, and we're going to continuously sort of spark some fire to a bunch of tinder, and this pandemic will just keep going on in nursing homes unabated.
Because of all the concerns of making COVID-only wings within nursing homes, some of the movement has been towards using temporary spaces to create COVID SNFs or COVID facilities. And so some states have used empty dormitories, empty hotels, or even convention centers to make dedicated SNFs to care for COVID patients after discharge from the hospital, which I can let Ashley talk or Josh talk about the staffing of those and whether that's feasible. But from a patient safety perspective, it's a reasonable thing to do. There are always going to be patients who can't go home for various reasons. Either they're too sick, or there's no one to help care for them, or there is vulnerable people in the house who can't risk being exposed to COVID infections. And so these types of COVID-only SNFs may be a reasonable solution, but they are expensive And over the long run, it's not really clear how sustainable this is. Like, how long are we going to keep people in the convention center in Boston recovering? We don't yet know enough about the course of recovery, the trajectory of recovery after COVID, to know how long people are going to have to remain in SNFs, though it looks like it's probably not. It looks like it's probably a long recovery. And so I think it's an option that we need to have, but it has the details of how best to do it haven't really been fully fleshed out, I think.
Right now, individual facilities are acting individually, and there really needs to be greater focus at the local level. So the baking in of nursing homes into emergency management and Department of Health conversations alongside the health system. Everyone in this situation, including skilled nursing facilities, brings strengths to the table. And if we worked in regional ways, which will look different in every state, we would then have the shared skills and strengths of government, hospitals, skilled nursing facilities, and the local community to meet the needs of what's happening at the community level.
There's a couple questions related back to workforce issues. Some of those workforce challenges I think we're touching on with respect to nursing homes, but I think we've spent less time talking about our home healthcare workforce. So Nina, could you talk a little bit about what you're hearing both locally and nationally in terms of in the same way that skilled nursing facilities, I see Josh posted an answer to one of the questions that there's some instances of nursing facilities that have had their workforce wiped out by positive cases, and being able to replace that workforce is a huge challenge. Are we seeing some of the same vulnerabilities in the home care workforce?
I don't think we've seen the same shortages or dramatic outbreaks among the home care workforce. And some of that is the great lengths to which the home care agencies are going to make sure that their workforces are safe. So for example, anytime one of our clinicians is going to go into a home, they ask screening questions, not just of the patient, but all of the household members, because unlike the hospital or the skilled nursing facility, we can't have visitation restrictions. Anybody who's in the home is in the home. And so we do that to know what we're getting into before we go in. And then in addition, all the cases with any risk are reviewed by infection control. And I know from speaking with other home care leaders that a lot of attention has gone into PPE. Similar to the skilled nursing facilities, home care agencies have some struggled with PPE, but those associated with healthcare systems in large part have been able to take advantage of that and be able to have, sufficient PPE, which we definitely have in our case. I think that the home care workforce is used to going into homes that might have safety concerns of different types all the time. I sometimes think of home care nurses as MacGyvers who are very creative and figure out how to make any environment work. So I think this is something that workforce is already used to doing, and now we're just adding PAPRs or N95s. We actually have one creative solution of vans that have PPE that can meet somebody at the home of a COVID positive patient, help the nurse don and doff safely, especially if it's raining, and then provide them actually some emotional support as well. And I've heard similar stories from other home care agencies. I think lastly, the thing that's helping us with workforce, despite our surge, is we've moved more of our visits to virtual visits, which cuts down on driving time and therefore actually has allowed us to care for more patients than before because we're using more technology and more remote monitoring.
I love the fact that you referenced MacGyver, a very old TV show. A friend of mine just let me know that it's streaming free on the internet for anyone who wants to watch it. So there's a very specific question here related to home health care, and that is a Medicare question. Do patients still need a face-to-face visit within 30 days for Medicare home health, or has Medicare allowed televisits to stand in place?
Yes, you can use televisits for the face-to-face, which is terrific.
Another technology question, which is, we've massively scaled up telehealth in many settings during the pandemic, but there may be many patients who, where post-acute care is very relevant for, particularly an aging population, where it may there may be some reticence to using some of the technology. There may be access issues related to technology. Are there ways that we're trying to address that? Are we seeing good examples of how to balance these competing demands?
Technology is really helpful, but has to be individualized. And the good news is there's a range of technology. So, for example, some home care agencies are using very simple pulse ox machines and thermometers, and then calling patients who aren't particularly technologically savvy. Somewhere in the middle, we work with a group and use tablets that we deliver to the patient's home. We do an in-person visit and demonstrate how it's used. It connects to things like a pulse ox monitor, so they don't have to worry about how to transmit. It's all within the solution, and they actually get set up in person with it. And then moving forward, that allows us to call them on the tablet twice a day, do a video visit, check their vital signs, do that level of monitoring that Rachel was talking about, which is almost like SNF or hospital level monitoring, but at home. And because we set it up and it's pretty intuitive, that works well even for older patients. We do have a group of patients who are very technologically savvy, and in that case, we can instruct them to download an app on their own device, and we can interact with them that way. We can do the same twice daily video visits, look at their work of breathing, talk to them about their symptoms, and then we can instruct them in how to input their own vital signs or data using other types of machines that we can mail out to them. So there's a range of solutions, and I think the lesson is you have to assess your individual patient, and then within your monitoring strategy, be able to accommodate everything from downloading apps to telephone calls. And it's nice in the home health world to be able to supplement that with visits if you have a patient who really needs an in-person visit.
There's a question that comes from an example from Maryland, and this may be a question for maybe Josh or Ashley, where Maryland's Governor Hogan created a strike force of hospital staff, public health officials, and National Guard to come into stressed nursing homes. Is this something that should be considered by other states?
A great example of just coordination between health systems, nursing homes, and state government. It is a fairly reactive strike force. The nursing home has to reach out for help. The National Guard goes in, they provide patient management for 1 to 2 days, and then they leave. So it's not the most ongoing relationship for these nursing homes. It is a short-term solution where it's basically a 911 for the whole facility. So it meets a very specific need. It certainly would be a key part of the process, but there's need for a more robust organization to meet information needs, staffing needs, material needs than this.
Rather than a nursing home needing to call for help in a true dire situation, are there some metrics that public health officials might monitor to say, we're seeing some stresses at an early stage? Like what might they look for?
The problem with coronavirus pandemic is the question is, do they have enough testing? Do they have enough PPE? Do they have enough staff? Are their infection control policies appropriate for asymptomatic spread? And then are they monitoring the patients with temperature and pulse ox as closely as they need to? Is their communication with families robust enough? And are they triaging the right patients to the hospital and not sending the wrong patients? But yes, you can make a checklist of those things and you would have a pretty good snapshot of if the nursing home is keeping its head above water or not.
All of you are clinicians, and I know as clinicians you often get informal calls from friends, family, other people in your social networks who might be facing this question right now of having a hospitalized family member who may need help, services in some way when they leave the hospital. And during the pandemic, maybe there's someone who would have obviously been referred to a skilled nursing facility. What kind of advice would you give a family facing this decision right now about this kind of trade-off, I think, that Rachel outlined earlier between care that you can get in a more robust way in a skilled nursing facility with some of the attendant risks versus going home and trying to manage with what are hopefully scaled up home care services during this time?
It's a hard question. It's obviously individual needs to be answered specifically for individuals and what the specific cases are. Though I think that given the challenges that SNFs are facing right now, if it was me or my family member, I would strongly encourage them to go home. I think there's one thing we haven't talked about, I don't think, related to SNFs right now, which is that patients are all in isolation. Like, they're isolated from family members. There's no visitors. And I think it's a really hard, it's both throughout the hospitalization and then through the SNF stay, which turns out to be could be a very long period of time. And I think that the combination of that social isolation and the potential ability to get a similar level of care at home where you're not socially isolated really, I think, swings the pendulum for me towards suggesting that people go home if they at all can.
I think it's definitely an individual preference, and many people have strong preferences to go home if they can. But Rachel, I think you hit the nail on the head with the isolation and the support that someone can get at home. In addition, when you get home services, you usually have one nurse intermittently coming in your home as opposed to many different caregivers in a SNF, and the ability to create a therapeutic relationship with a smaller team during a scary time. So I think we are definitely seeing a swing towards patients really wanting everything done at home if possible. We've seen this with our infusion services. They would rather have someone come to their home for infusions they previously wanted to go to infusion suite. We've seen it for some other types of non-COVID hospitalizations too, that if they can go home, they're really favoring that at the moment.
The two things that I'd like to point out are that there's extreme guilt in situations where someone has to go into a skilled nursing facility, and we need to provide support for caregivers and family members in situations where a nursing home really is the only option and the best option for their care. The second thing that I believe is important is there's this opportunity for individuals that have not been hospitalized yet or have not experienced a health crisis to really have critical conversations about what kind of care you would want, what the backup team would look like, and how we might onboard people to electronic mediums to communicate before you need them. And I think that those conversations are vital to have now.
Ashley said something that I care a lot about, which is don't make families feel guilty when you are making these tough trade-off decisions for which there's no clear-cut answer. You have to meet people where they're at. If they can take their loved one home, I think during the pandemic it's safer and less socially isolating. But if they can't and they need to use a nursing home, then pick one that they feel is doing a good job and place their loved one there.
Before I get to a wrap-up question, there's a few questions that are related to the idea that there's a lot of unemployment right now. There's a lot of people that are looking for work. There are students who have in some cases been displaced by their training. And there's this need in skilled nursing facilities. Is there any kind of opportunity there for rapid training, deployment, or is there too much of a gap between the training needs and the safety in the environment to really think about that being a workable model of trying to rapidly train and deploy?
I believe that there's great capacity to train and deploy, and we should be looking at those options in regional areas. I believe that schools of nursing could be effective in helping to provide training. There are training programs in place in many areas for nursing assistants. Generally, those are not long courses, and so you could onboard individuals. But I do think that there needs to be investment at a federal level at providing these opportunities and encouraging workforce to move into those opportunities that were administered at the local level.
We're getting close to the top of the hour. I do want to ask all of you to respond to the question, which is, if there's one big thing that either the federal or state government could be doing now to, when we look back at the pandemic, to say, that we did something well, we averted a lot of, fatalities. What would be an important thing that we would look back on a year from now to say that we did that made a difference. And then, if you want to comment on whether that's the type of thing that we hope will endure after the pandemic in some way.
The problem with running a nursing home is that the Department of Health sometimes supplies testing and has some supply of PPE, but they don't have to manage the day-to-day issues of the pandemic, including palliative care. There's FEMA resources, there's the Healthcare Association of Pennsylvania. So there's no coherent one-stop shop where you outreach to nursing homes to assess a checklist to see how they're doing, PPE testing, staffing, clinical management, coordination of lab and diagnostic support. There's no way to compensate for the staffing shortage, and it's not run by geriatricians or physicians in this medical emergency and medical disaster. And so there's a need, sort of a virtual command center to pull everything together, but that requires support from health systems, the nursing homes, the government, and different agencies within the government. And there just isn't the appetite to put that amount of effort into this.
Ashley, you want to take that one next?
I want to echo what Josh is saying, that nursing homes sit between communities and the healthcare system, and many times there's nobody in charge. They're sitting between these two systems, and it's hard to move things forward. What I would love to see as a response to this pandemic is that we work in collaboration to bring opportunities to communities for both economic and employment, for collaboration across all of the levels of care, not just nursing homes and home health industries, but social support services, integrated behavioral health, that we really, at the other side of this, have built communities that are able to care for older adults and individuals with complex medical and social needs.
Nina?
I think the flexibility that payers and the government have started to embark on, allowing more flexibility for home health care delivery with respect to more virtual visits, telehealth, some of the relaxed requirements, has been very positive and has allowed a lot of sick patients to stay home. They're doing everything from twice daily vital monitoring to IV fluids to oxygen. And I just think about if even half of those home health patients were instead in a hospital, how that would have impacted our hospital capacity. Taking half the home health patients and putting them in the hospital would have pushed many of our hospitals, for example, past their bed capacity. So I think we've learned a lot in how home health can take care of very sick patients creatively at home. And I hope that we continue in that direction in terms of more flexibility for home health requirements and payment models.
Rachel, I'm going to give you the last word.
You asked, what can we do now to save lives? And so I have a very specific answer to that, which is I think if we want to save lives, we need to do widespread testing and contact tracing for people in nursing homes, for the workforce, and for the community at large. And I think a year from now, we're going to look back and say, I'm really glad we did that, because that is going to save lives. With regards to post-acute care and long-term care, though, specifically, I hope that the changes that we've made and the innovations that we've made to delivery of care, specifically at home, are long-lasting. I hope these aren't temporary changes to the way that we deliver care, because I think there's real benefits, and I think Nina has outlined those. But I think there's a bigger issue, which is what I hope we can carry with us as we move forward through this pandemic, which is that if we've learned one thing, it should be that the long-term care system in this country is fundamentally broken, and that we have undervalued it and underpaid for it for decades. And I think that we've exposed this. It's become very apparent through the COVID pandemic that this is true because of all the struggles that people have described today in delivering care to sick patients and keeping the infection under control during the pandemic. But it's not just the pandemic that is causing these problems. We have a fundamentally broken system, and I think that we need to think about how we're going to fix the system by having a universal way to pay for long-term care for everybody in this country in a way that fully compensates the people who are providing it. A small ask.
Yeah, small one, but important to certainly put forward. I think, again, The challenges we face are enormous right now, and I want to thank each of you for really helping shed light, I think, on what is a critical issue during this pandemic, but not just shining a light on the critical issue, but I think bringing some important ideas forward on solutions. And hopefully we'll start to see a more robust response to really try to bring some of these ideas forward. So I want to thank all of you for tuning in. Again, this was the fourth in our series of virtual seminars, and we do hope you will join us again in 2 weeks as we tackle another important issue, which is really the collision of the COVID pandemic alongside the opioid epidemic. So thank you very much, and stay safe, and hopefully you can have a great weekend.